Okay, so I'm going to go through chapter 47, and we're going to start with acute kidney injury or kidney failure. So there's chronic and there's acute, and we're just going to go over acute right now. Okay, by definition, acute is going to be severe with a sudden onset. All right. The chronic, of course, is ongoing and it has detrimental effects. It's usually the mortality rate associated with both of these is pretty high, but the severity of it is less and the duration is longer on the chronic. All right, so acute kidney injury. First of all, if we can understand what the kidneys do, it really helps out to figure out what it's not going to do or how it's going to manifest itself in possible treatments. Quick definition here. So azotemia is the accumulation of waste in the body. Okay. So what does the kidneys do? The kidneys filter out blood. They filter waste from our body, right? They are responsible for our pH. We talked about that before. They help get rid of toxins, urine output. So they're going to, or volume in our body. I don't know if you remember us talking about that, but they play a part in red blood cells. So the kidneys do tons of stuff. So when we think about what happens when we have kidney failure, well, all of these are going to be affected. All right, so they pretty much got it broken down into three different parts. You have, let me just draw a little guy because I think it's, so we have our guy. There's our guy. And here's his kidneys. Okay, so the way that they have the acute kidney injury set up is basically like three different causes. You can have the causes be pre-renal, intra-renal, and post. So pre-renal is everything before it gets to the actual renal system itself. So it's all of this before the renal system. Okay, so that means that it could be septic, it could be anything that has to do with things that might affect it. It's not from the kidney itself. Now, intra, of course, is inside, and that tells us that it's inside the kidney. All right, so pre-renal causes, intrarenal causes, and then post, of course, well, this means it's after the kidneys, which means it's going to have to do with our bladder at this point, because everything after that is bladder and urethra. So post is after kidneys. Pre-renal is before, obviously. All right, so what are some of the things that can affect our renal system? Well, we can talk about the fact that hydration, our hydration level is going to play a huge factor here, and of course that plays a factor into UTI. Pre-renal, again, we've blood flow reduction or too much blood flow. So if we have blood flow systemically throughout our body, eventually it's going to affect our liver, and it will eventually lead to death or necrosis, which becomes intra. All right, so those are just some examples of pre-renal. Intra is a failure inside the kidney itself, and this a lot of times is going to be an infection or inflammation. And the interstitial, that's another term they use in there, interstitial nephritis. Interstitial nephritis. All right, so we know that it's inflammation of the nephron, which again is the functioning part of the kidney, and interstitial means that it's inter or between. All right, so it's between the actual renal pelvises where they have inflammation. So if you see that interstitial nephritis, that's what it means. It just means in between the nephrons, and there's inflammation. Okay. So, and then post, that means that it's going to occur in the bladder or urethra. What happens there? Well, we could have cancer, we could have trauma, we could have We could have calculi, a lot of prostate issues. And this is going to involve, when we talk about this, is going to involve some type of backflow of urine. So there's going to be a lot of backflow of urine, and you're also going to have that hydro. I don't know if you remember this, but hydro nephrosis, which is just a dilation of the blood vessels and that are inside of our kidneys. Now, if we have a blockage in some area leaving our body, so the urine's building up, it's building up, it's building up. When we have that issue, we are, of course, going to have an increased amount of pressure. And when we have increased amount of pressure, well, you're going to eventually ruin some of your renal system. All right, so increase in volume means increase in pressure, and the same thing could be applied to blood pressure as well. All right, also hypovolemia. So what can cause hypovolemia besides dehydration? What about burns? All right, burns are going to play a huge factor here, and again, that's. Oops, I'm sorry, I wrote down the wrong spot. Burns are going to be your pre-renal. All right, it's not an injury necessarily to the kidneys, but if we have low fluid volume, low blood flow, we've had trauma, we've had blood loss, we've had burns, we've had low hydration, we've had nausea and vomiting. Anything where you start to lose fluid is going to affect that, and that's going to be pre-renal. You also have things like, for instance, if you have cancer, some part of your body, we give you chemotherapy, we're pretty much giving you a toxin, all right? And that could be not directly hurting the kidneys, but hurting the system, which will eventually affect our kidneys, okay? All right. That's the other one, toxics, now that I'm on here. So toxic, and it could be intra, where it's directly affecting the kidney, or it could be outside of it. So toxins would be another one. When we think of toxins, though, if they were to ask, is it pre-renal or intra, then you probably want to stay with that intra, because remember, all toxins are going to have to be filtered out of the body somehow, and that's by the renal system. So you could consider that in that sense a direct cause of kidney injury. All right. Infection, allergies. Oh, allergies was the other one here. I totally forgot about that. Allergies. So you might find that you have a urine specimen that contains not just white blood cells, but your specific ESO, and I just kind of remember it that way, but there's a specific white blood cell that affects our allergic reaction, and we'll talk about that in a little bit. But anyways, all right. So these are all the causes. Again, there's pre-renal, kidney, or intrarenal, and post. So it's either before the kidney, inside the kidney, or after the kidney. Okay, and those are how they break up the causes. And it's important to know the causes, because if we don't know the cause, we really can't effectively treat something. I'm just randomly guessing at that point, which is never a good thing to do. All right, so again, back to what does the kidneys do for us? It's going to pretty much tell you your manifestations. If I can think of what the kidneys do, I can think of what's going to happen when they don't work. Okay, so our symptoms or manifestations, however you want to see that, is going to be you're going to have high red blood cell. Red blood cell, CAS specifically, again, that comes from the upper urinary tract. So CAS, same thing could be applied to white blood cells. And I just said that it filtered out waste. So what's going to happen? You're going to have a buildup of waste in the body. Waste, what type of waste? Well, you're going to have a high level of calcium, because calcium should be excreted in the kidneys. Kidneys aren't working, then calcium's going to stay in the body. All right. You're also going to have a buildup of hydrogen. We didn't talk about this, but as far as pH goes, bicarb is going to be important, and ammonia. Ammonia helps excrete hydrogen. Without ammonia, there's nothing to bond to hydrogen to. So those hydrogen ions just kind of build up in the body, and that's how it affects pH. All right, what else does it do? It filters waste, filters toxins. It regulates our volume. It regulates blood pressure. So your blood pressure is going to probably be out of control. You're probably going to have fluid retention, because if I can't get you to urinate, where is the fluid going to go? It's going to stay in your body. When I have increased fluid, I have increased pressure. When I have increased pressure, I have a higher blood pressure, right? Too easy. Increased fluid is increased blood pressure 90% of the time. Low sodium in your serum. Now this is because your body wants to hang on to some sodium, but if it's not working, it's possible that the sodium's just being excreted constantly if they still actually have some type of urine output. In which case your serum sodium, or the amount in your blood, will be low. Let's see. Oh, acidosis. You're going to have acidosis. Why? Well, I just said we have this, right? And this directly relates to acidosis. So if I have high hydrogen levels in the body, that means I'm going to be acidic. Besides the fact that it also reduces bicarb, which makes strong acids weaker in the body, you're going to have acidosis or acidic reactions. And of course, that's a whole other list of manifestations. You're going to have those respiratory rates going to be affected, all types of neurological problems, and especially with potassium. Potassium directly relates to the heart. So if I have high level or low level of potassium, I'm going to have direct effect on the heart. And this is going to throw you all through the roof with heart failure. When I have fluid retention, a lot of times that's going to build to edema, and that edema is going to eventually surround our heart. And when it does surround our heart, it's called congestive heart failure. I'm going to spell this out for you now. Eosinophil. I just remember the eso because I think of environment, and I think directly for allergies. So anyways, you might find that these are in your some of your UAs, and this means that it's an allergic reaction. This is a reaction for histamine. When we have an allergic reaction, you'll see it in when you have anaphylactic shock, things of that nature, or an allergic reaction, regardless of where it happens in the body. All right, let's make sure I hit everything there. Oh, low gravity is another thing you'll see, and obviously low output, if I haven't said that already. Low output, all right, low output of urine, and the specific term that they're going to use for that is low output is oligurate phase. All right. Just so you know, this is not like A in the sense that there's no urine output. It just means that there's less than 400 milliliters per day of urine output, which is horrible, as you know. So we don't have all of it gone, but we have some of it gone. So this is kind of like you're halfway in between. So you're halfway in between being functional. All right. So 400 milliliters or less a day of urine output. And this is actually one of the phases, and we'll talk about that in a second. Okay, so these are just some of the ways. And if you can think about what the kidneys do for you, then you can think about what they're not going to do for you when they're not working. So let's talk about these phases, and that includes your urea. So they've got it broken up into pretty much 3 phases. You have where your urine output, and this isn't in all patients, but so it's not always the case, but oliguric phase, and this is where you're having urine output of less than 400 milliliters a day. Also with that fluid retention, you're looking for jugular distension, maybe fluid in the lung, edema, especially in your low pressure areas, i.e. underneath your eyes. So those are some of the ways. You have your diuretic phase, and then of course you have your recovery. Alright, so the way that they have this laid out is that the first phase that you would be in is here. And that's where you're going to have urine output of less than 400 milliliters a day. So at this point, the kidneys are barely functioning. They're just kind of limping along. Our biggest thing here is that we're trying to figure out what's the cause and what stage is it. Was it pre-renal, post-renal? Is it something wrong with the kidneys themselves? As a side note, for your diagnostic test, you can of course look at UAs. You might look at an ultrasound, but contrast medium is not recommended, and that's because if your kidneys are not being able to filter out anything, if they can't filter out the waste, then how are they going to filter out the contrast medium? And what you end up with is pretty much, making the kidneys even more ineffective than they already are. So no contrast medium. Biopsy is of course going to be your most accurate test as far as where are we having these issues at. You can also use some CT scans, MRIs, as long as it doesn't have that contrast medium. And then of course we're going to look at our labs here for our UA. We want to know our electrolyte values. We want to know clearance, bun levels, things of that nature. All right, diuretic phase. Your diuretic phase at this point, diuresis. It means that you're getting tons of fluid out, up to 5 liters of output, up to 5 liters of output a day. That doesn't mean your kidneys are functioning. It means that they can't figure out, they are functioning to a certain extent, but can't figure out what to hold on to. So you're really going to need to watch your electrolyte values and make sure that your patients are completely not hypervolemic at that point, or too much fluid. So you really want to watch your electrolyte values here, and make sure that they're getting proper nutrition, okay? But it is a good sign, and they would move into recovery phase. That can take up to 12 months. It's a long time, and obviously the quicker we catch it, the less damage it will have to the kidneys, and the quicker it will be resolved. So the whole thing is figure out what's causing it, and then start from there. Once we can figure out what's causing it, we can talk about, well, maybe it's an outside thing and it's a toxin, or it's something to do with the bladder. So let's go ahead and make sure that we have some type of diversion for urine. Whatever it is, we want to know the cause so that we can make sure we have the right treatment as soon as possible for this. And again, mortality rate is pretty high for this, so you want to make sure that you're treating this quickly. Your biggest concern, though, is going to be that high potassium. All right, potassium is really not a great thing at all to have a lot or too little of, because, like I said, it directly affects your heart. All right, so let's talk about treatment for calcium. The treatment for calcium. So when we're talking about calcium being too high, obviously if it's too low, you give more. I keep calling it calcium. This is definitely potassium. This is not calcium. All right, we're not talking about calcium. I'm talking about potassium. All right, so because potassium, if it's too low, you just give more potassium. But when it's too high, we need to figure out what to do with it. So some of the things that we can do for an immediate result is insulin, which is going to push. Insulin pretty much acts like a gatekeeper in that if I give them insulin, I can start pushing things into the cells, whether it had been, glucose or potassium in this case. I can start pushing things into the cells. Your other one that you can do is sodium bicarb. Sodium bicarb, if you remember back, sodium bicarb is going to take that strong acid and make it weaker. So it's fixing the acidosis issue. So, and then calcium, other one is calcium gluconate, given by IV. Calcium gluconate is pretty much going to raise your the amount of stimulation needed to excite the heart. Basically what I'm doing is I'm trying to raise the threshold that activates this heart to beat. And the reason I'm doing that is because, like I said, calcium is directly going to affect the potassium is going to directly affect the heart. If I can reduce, if I can't reduce it at the time, at least I can prevent the heart from being as stimulated by the high levels of potassium. All right. These are all just temporary fixes, because obviously if I put it into the cell, then the cell is still there. I haven't gotten rid of the potassium. If I reduce the amount of acid in the body, again, I'm reducing it, but has the potassium left? No. And this, which is going to help with our dysrhythmias, Again, not fixing the real problem. The only way to get rid of this stuff, how do I get rid of potassium? I can go through dialysis, or K-Escalate, and I think about K-Execute, or kill, K-Escalate or K-Execute, is going to get that potassium flushed out of your body. So those are the treatments that you can use for high potassium. Of course, you're going to restrict. You're going to restrict dietary. It would make no sense to not restrict this if I'm trying to get rid of it. 40 milliequivalents a day. You can also try diuretics, but it's important that when you go to use diuretics with any of your acute kidney injury, is that are you actually able to excrete anything? If I increase diuretics and can't excrete anything, then I'm going to also have an issue. All right, so what do we do to treat acute kidney injury besides treating the high potassium? And once we figure out the cause, again, that's when you can figure out the treatment. But some of the other things that we could do is going to be nutritional, fluid intakes, things like that. Now, initially, you don't want to increase fluids, and the reason why we don't is because if the body is not able to excrete them, well, all I'm doing is going to increase the amount of fluid in my body, which is going to further increase my blood pressure, the hypertension, dysrhythmias, things of that nature. So some type of fluid restriction. Obviously, you're going to have nutritional restriction. So lower sodium, and again, this all depends on your lab values, but lower potassium. You might try dialysis. Again, that will actually start flushing things out. And then nutrition is still going to be important, but most of your nutrition should be coming from carbohydrates and fats at this point. And your fluid, there is a calculation for this fluid, but pretty much it's whatever you lost the 24 hours before, plus your insensible water loss, which is generally, and again, insensible water loss is, lost through the skin, evaporation, things like that. So 24 hours, what have you lost in that? What was your output? Then I add on 600 milliliters, and that's what my fluid restriction, the amount that my patient is allowed to take in. So those are some of the treatments that you can use. Obviously, close monitoring is going to be essential here. EKGs going to be another essential thing that you need to watch out for. But that is going to sum up acute kidney injury. Now, again, it is reversible, whereas when we go into a chronic, it's not. But you've got to treat it as quickly as you possibly can. So.